Good evening, everybody. Thank you very much for joining us for this live webinar from Paris. It's a great pleasure to be with you and to be with this team tonight. It is a joint webinar between the PCR Tricuspid Focus Group and the European Association of Cardiovascular Imaging, and we will learn how to image patient refer for tricuspid transcatheter intervention tonight. So I have the tremendous pleasure to be here with Bernard Cozins, who is the immediate past president of the European Association of Cardiovascular Imaging. And before I give you the word, Bernard, I would like to remind everybody that this webinar is interactive, and at any time during the evening, we will give you the priority. We will answer your question, and we will see directly your question coming to us and try to do our best to clarify any question you have and you want to address to our expert. Bernard, I give you the word. Welcome.
Thank you very much, Fabien. It's a real pleasure to be here with such a fantastic panel and also friends around the table. Let me introduce the team. Of course, you know already Fabien Praz from Bern, Switzerland. He will be my co-chair today. We have also with us Nina Ajmoun-Marsan from Leiden, Netherlands. We have Erwan Donal from Rennes, France. And last but not least, we have Denis Amouao from Milano, Italy. And then let me also introduce the learning objectives. So we want to highlight the use of imaging to better understand the anatomy of this complex valve and also the mechanism of dysfunction in view of potential tricuspid regurgitation intervention, and also to learn you how to use imaging in order to select the more appropriately the patient referred for tricuspid regurgitation in order to have this transcatheter intervention, and also to guide the procedures. So we will first start with Erwan, that will probably give us a glimpse of the patients that you will show in a live case at the end of the webinar. So maybe, Erwan, can you give us some details about this patient?
Yes, I can. We discussed the case in the art team with the surgeon, the anesthesiologist, the cardiologist of the team. I will join them in 30 minutes to do the case. So this is a man, 70 years old, a man, hospitalized twice for heart failure. This is a patient in chronic AFib with a chronic hypertension also. He has a COPD and is now treated with 125 milligrams of furosemide. So the TRI-score is 6/12, so it means that the risk of in-hospital mortality is 22%. And then we decided to send the patient to the cath lab for a triclip intervention.
Okay, this is excellent. We cannot wait to see you in the cath lab. So in the meanwhile, we will give the word to Denisa to have a short presentation on the anatomy and dysfunction of tricuspid regurgitation. Please, Denisa.
Thank you, Bernard. Dear colleagues, it's a great pleasure for me to discuss the patient selection criteria. So, indeed, this is really an important part of the patient evaluation. And as Erwan has just mentioned, this is a decision that should be shared among different colleagues. And the interventional part is important, but the imager has a very important role in order to understand the indication. So, as you know, according to the guidelines, we have the patient should have a severe tricuspid regurgitation and should be symptomatic. But in order to establish the indication, most importantly is to be aware that the color Doppler is not only unreliable, but should no longer be used in order to assess the severity of the tricuspid regurgitation. We should quantify the regurgitation severity and using different parameters. We were saying that in order to select the patients for surgery, for interventional procedure, First of all, we need to make sure that we are respecting the guidelines, because only patients with severe or massive or torrential TR may be considered for this. And I was saying that anatomy is important because you need to make sure that the tricuspid valve anatomy is anatomically suitable to be treated with most frequently edge-to-edge repair. And finally, you need to make sure that the patient has a high probability to improve after this intervention. So it has to fulfill certain characteristics. Regarding the tricuspid regurgitation severity, I mentioned before that the color Doppler should no longer be used because it is quite unreliable. If you have a patient with RV dysfunction and low cardiac output, the TR is quite small and does not make a rising, so we should quantitate, including many parameters. 2D, biplane, 3D echo are recommended nowadays. Since there is a linear relationship between these parameters and mortality, we should not only provide the grading, but also the numbers. And we should try always to include them in the report or to ask them for the imager. PISA method may underestimate error in secondary TR because of the very irregular shape of the regurgitation orifice. And we now know that if there is a significant tethering of the valve, we should also apply angle correction in order to not underestimate the severity. More frequently, it is a problem of underestimating, far less is the problem of overestimating the severity. So the imager should be aware of all these issues. And once that we have a patient with severe TR who can be a candidate for an intervention, we need to further stratify. So it's important to clarify how severe is actually a severe TR. And you see these parameters, not only ERA, but also 3D vena contracta and regurgitant volume and regurgitant fraction. We know that the tricuspid valve is challenging because it's thinner and there are a lot of other issues on the right side compared to the mitral valve. We also have a present pacemaker or ICD leads that make things really challenging. We have the problem of acoustic shadowing from highly reflective structures. So seeing the leaflets is not always very easy, but with some training and experience, we can work it out. Why it's important to see the leaflet? So first of all, because we have learned that the tricuspid valve can be really variable and may have also 4 leaflets or 5 leaflets. And when you go down into this classification proposed by Becky Hahn, the complexity of the intervention increases. So it is much easier to repair with a 3-clip, 3-leaflet or a bi-leaflet valve than one with 4 or even 5. And these are not really rare cases, as you can see. You need to also be able to identify the position of the papillary muscles to understand and identify the leaflets. So the imager should be able to provide this classification in order to facilitate the communication in the cath lab. Another important aspect is the assessment of the right ventricular function and the size and dimensions of the right atrium. This is an example of a patient, 84-year-old man with permanent atrial fibrillation, a severe secondary tricuspid regurgitation, in which you can see that the conventional parameters, but also 3D ejection fraction is normal. But if you look at the parameters of deformation, like three-wall longitudinal strain, is already impaired, which means that most of the parameters that we routinely use, including ejection fraction in these patients, are low dependent and might overestimate the real systolic function of the right ventricle. So we need to be aware of it and to use as much as possible more sensitive parameters like strain. Finally, we have the possibility to provide quantitative measurements for the annular size. The leaflet tethering, the coaptation gap is really important to be sized, and usually is done by transesophageal echocardiography to the higher spatial resolution. And measurements, we need to know when to do them because it may affect their reliable estimation. For instance, the annular size, we know that we should measure it in diastole, but the coaptation gap, of course, should be measured in systole and so on. Finally, the imager should be able also to provide a systematic evaluation of the gap extension and the gap size using this sweep in the inflow-outflow view from the most posterior to the most anterior part of the tricuspid valve. And this is important to localize where it is at the level, the largest regurgitant orifice, because this is where the grasping will have to be done. And the imager should verify the quality also without color of the visualization of the leaflets. This is an example that this biplane view is really important also to assess pre and post clip and to evaluate the entity of the regurgitation after clipping. Keep in mind that if you use 3D, you should also include anatomical landmarks. Finally, assessing the feasibility for intervention includes the biplane, the bicaval view in order to exclude the presence of potential complications like thrombi that may complicate the procedure, and also a very evident Eustachian valve. And for some other interventions, you need to make sure that you have adequate access and also adequate dimensions of the annulus. Finally, these are my last messages. So first of all, optimize diuretic treatment before the patient screening, because this will affect also the TR severity and the gap size. So usually these patients have to undergo a diuretic treatment just before the intervention. If you have a natural secondary TR, you need to consider rhythm control because this may improve the TR. You have to use transthoracic for assessing the severity, but transesophageal echocardiography is a must for assessing the anatomy. And finally, don't forget to check the image quality in supine position, because it may be completely different than the images taken in the echo lab. And finally, we also need other parameters from the right heart catheterization and functional tests to make sure that the patient has indication and to exclude a severe pulmonary pressure and precapillary pulmonary hypertension. Thank you very much, and I'm sorry for these technical issues.
No problem, Denisa. Thank you very much for the talk. I'm always very impressed by the beauty of your images, but you have shown us also what are the challenges and what are the difficulty to image the tricuspid valve. And also one very important point, you mentioned that underestimation of the severity of disease is also very important on the right side. I just have a question. When we go now into the intervention or imaging for deciding to refer a patient, there are a lot of parameters you have mentioned: coaptation gap, the function of the right ventricle, some indicator of the pulmonary hypertension. What maybe we don't know the answer yet to that question, but what could be one of the parameters that indicate us that this patient is too late for an intervention, or that the effect of the intervention would not be beneficial to a patient?
Indeed, we don't have many data on that, and from an imaging standpoint, probably the most impactful parameter is the RV function. There is no, as I said, there's no ideal parameter to assess at the moment the right ventricular systolic function, but it seems that global parameters like RV ejection fraction, either by 3D or CMR, are more predictive of the poor outcome than TAPSE and fractional area change, and recently also RVPA coupling parameters. So when you have a patient with really severe dysfunction of the right ventricle, and you have also evidence of, for instance, of late gadolinium enhancement with CMR, extensive, transmural, maybe the patient had RV infarction, then there is really a low probability that the patient will have a good benefit even after you clip the tricuspid valve. And of course, there is also show the presence of severe LV dysfunction and comorbidities, clinical parameters like severe renal dysfunction or cirrhosis or other frailty of the patient. But from an imaging point, I think the RV dysfunction.
I think that's a very important message. Also, you said look at the left side as well, and the complexity of the right ventricular function. Bernard.
Yeah, we have some questions. Maybe I can ask to Nina because she has a lot of experience also in referring patients to this procedure. So when should we refer? When is it too late? Do we have to wait for symptoms? Or can we already propose some patients when they have only a moderate tricuspid regurgitation? What is your experience about that?
Well, I think it's a great point because indeed we are afraid to be too late, but maybe we should not be afraid to be too early because we learned from the beautiful presentation of Denise that we underestimate the tricuspid regurg. Therefore, when we think is moderate, it's probably severe. And if we wait for symptoms, and mainly symptoms are considered under diuretics, maybe high dosage of diuretics, patients remain asymptomatic, but they are dependent on diuretics. So I hope with the experience of these procedures, we're learning that we should be earlier and we should be aware of the problem and consider intervention much earlier, considering these problems in the estimation. So be aware, be earlier.
That's a very important point, and there is a question exactly linking to what you just mentioned. Maybe to you, Erwan, the role of stress test in the early diagnosis of patient, exercise, echocardiography. What do you think? Is there any experience on that? Do you have some?
There is no data on the literature yet, but yes, I have some experience. The fact is that there is a vicious circle between afterload and AFib, between ventricular TR and atrial TR. And sometimes it's challenging to know if the patient is symptomatic because of the tricuspid rigors. So if we can do just a diastolic stress test, increasing the heart rate to 120, it's just good enough to see that the TR might become torrential during exercise, and then you can be convinced that the patient should be treated.
There is another question regarding vascular resistance and pulmonary hypertension from the audience. Do you think that stress echocardiography can unmask pulmonary hypertension or can be helpful to assess this as well?
Actually, most of our patients have a heart failure with preserved ejection fraction. So in that case, that's true that sometimes you have no pulmonary hypertension at rest, and as soon as you increase the heart rate, you have a pulmonary hypertension. So it could be a good idea, yes, to test that.
But we don't know exactly
But
yet.
we don't know yet, and actually we don't know if treating a patient with a pulmonary hypertension, an exercise-induced pulmonary hypertension is harmful. We don't know yet. So,
Denisa, we have also a question. So you brilliantly showed that we have different phenotypes of tricuspid regurgitation. We have the primary, we have the secondary, and we have the atrial one. So do we have in some case a mixed disease, mixed phenotypes, and do you manage these patients differently and depending on the phenotype of the presence of a mixed phenotype?
Yeah, very good question. Indeed, there is the proposal to classify these patients in atrial functional tricuspid regurgitation and ventricular functional tricuspid regurgitation and pacemaker because we have quite different management. As I said, for instance, we have to recommend cardioversion or ablation of atrial fibrillation in the attempt to reduce the tricuspid regurgitation. But when the situation is mixed and you might have a pacemaker and atrial fibrillation, things are not always easy. And when you see the patient for the first time, it may be challenging to understand which was the primary cause of the tricuspid regurgitation. We need to understand which is the main mechanism in that case, which is the main player in the occurrence of progression of the tricuspid regurgitation, and try to understand if we have the possibility to have a documentation of the progression with imaging of the patient to understand what has been the primary event. Atrial fibrillation has preceded the implantation of the pacemaker, or there was superimposed pulmonary hypertension and so on. But many times we have just one, and it's simpler. When the patient comes in a very advanced stage, there may be mixed patterns.
So you mentioned briefly the pacemakers. So echo, for example, could be very useful, especially 3D echo, to make the difference between a primary TR related to the lead or related to a secondary mechanism, right ventricular dysfunction related to the pacing, and so on. So I think it's indeed very important to make the difference to assess, I think, the better management for the patients. So I think it's time now to move to the case, I think. No, or maybe Nina will indeed present about how to proceed during the procedure and how to perform the imaging in these circumstances. Please, Nina.
Thank you. So indeed, now we move to the details on how to guide these procedures in the cath lab. And I think this is particularly important for the imager, but also for the interventionalist. And I will focus mainly on the, indeed, edge-to-edge repair, but with a very small mention also of the tricuspid valve annuloplasty. That is another option for these patients, especially in case of, indeed, atrioventricular TR. And let's share with the edge-to-edge repair a lot of aspects, but there's also some very specific ones that is important to mention. And I'm sure that Erwan, when he will present his case, he will make it appear very simple to guide this procedure, but it's actually very challenging also for experienced imager. And we've seen already in the previous presentation which are the challenges. The tricuspid valve is very anterior, far from our probe, a very small leaflet, and a very complex and variable structure. So we as an imager, we have to learn to orient, to identify the correct structure, the correct leaflet, the commissure, the annulus, etc., which is quite challenging considering the overall imaging problems. And indeed, we might have a problem of shadowing coming from left heart prosthesis, even at the level of the intraarterial septum device. The valve is often crowded with the leads, and the system itself can shadow the view. So we need to know this a little bit up front. You don't have to test it, but this kind of image, as I show you here in this example, doesn't mean that are contraindication to do the procedure, but you need to be aware that you can use other views to eventually guide the procedure itself. So all the experts, both from Europe and from America, has actually published already sort of guidelines of which images you should use, you could use, and you should master actually to guide the procedure. But if some of those are not possible, you can have, of course, the possibility of using others. So I really suggest you to look at all this approach, and we will now go through a little bit the step of it. But as you can see in the middle picture, and where approximately the annulus and the level of the tricuspid valve is, we use mainly mid-esophageal views, going then more distally until a deep esophageal, and then we have the transgastric and the very deep transgastric view. So starting indeed with the mid-esophageal, more or less at 0 degrees, you have a classical 4-chamber. And here the tips is to try to go a little bit deeper, more distal, eventually adding few degrees to have the intraarterial septum as perpendicular as possible in order that you are very well aligned and you can certainly see very well the septal leaflet. And the opposed leaflet that sometimes is not clear is the posterior or the anterior. But if you go deeper, as I show in the lower right panel, you will go to the level of the coronary sinus and you are sure that the other leaflet is the anterior one. And this is a very good view that you can also use in case you have shadowing from the left heart structures, and you can therefore visualize the leaflet much better. Another very important view, if you maintain indeed the mid-esophageal view, to go more towards 60, even sometimes 90 degrees, and is what is called the intercommissural view. Because from this view, on the left side, you will have the posterior leaflet, and going towards the aorta, you will have the anterior leaflet. So doing this sweep moving of your trackball on the biplane mode, you will indeed go from the posterior leaflet to the anterior leaflet, as always opposed to the septal leaflet. So as you can see on the right side, you can always look where the leakage is coming from and what is the gap. Same with the transgastric view. Here, as you can see, the transgastric view is the only view where you can have all the three leaflets in one view. The posterior up, the septal, of course, to the right, and the anterior down. And with the color, you can identify immediately the origin of your leakage of the jet. And applying the biplane view as you go further to the right, you can indeed explore the coaptation gap between the different leaflets, and the same with the color. And in the upper part, you see instead the deep transgastric view. This is a very important view to have a view of the leaflet and of the grasping, especially when you have not very good mid-esophageal views. So you can really explore all this possibility. And finally is the 3D that, as Denise already showed you, has become really crucial in this procedure. You can have an overview, especially if you keep the landmarks of the other structure. And you can see in this nice representation, when you see the mitral valve, you can identify very easily the septal leaflet of the tricuspid. And when you see the coronary sinus, you will have the posterior at that side, and the other opposed is the anterior. So when we speak with interventionalists, we can easily say, move towards the aortic, anterior or posterior, and from the septal to the lateral, really orienting very well on how to move the clip, as you can see in the middle film. So let's see exactly what happens when you do the procedure. So speaking about edge-to-edge repair, we dive into the valve, actually trying to keep the clip in the middle. So using the intercommissural view, we can orient posterior-anterior, as you can see with the arrow, and then switch transgastric, where we will see the alignment of the arms, in this case very well in the middle, so that we are diving without interfering with chorda or other structure like the papillary muscles. Then we have to decide indeed where to put our clip. As you can see in the schematic on the left upper part, the target for this kind of procedure are normally the anteroseptal, so the lower part where we can put 1 or 2 clips, but also posteroseptal could be an option. So once you identify where your leakage is, you will decide where you put your clip. Be aware that if you think a clip is necessary at the posteroseptal position, that will be only in a second phase, because as you can see just below the schematic, if you place a clip in the posteroseptal position, it will give you a lot of shadow and you will not see anymore the anteroseptal commissure. So always plan it eventually as the last. And when you start from the anteroseptal, if we switch to the right side of the screen, you can see that sometimes the gap, coaptation gap, is so big that we need to first approximate the leaflet. So here in this case, as you can see, we place the first clip very much anterior, very much into the commissure between the anterosepta, as you can see next to the aorta. And only later we place the second one once we approximated the leaflet, and we can finally grasp more centrally. As you can see, the clip is more to the center. So very often there is this approach with 2 clips to really target our leakage. And here, just below the schematic, you see exactly the same patient with the clip, first more into the commissure, another one more centrally. And in this case, we, as you can see, reduce very much the opening. And I put another very extreme case in which we put 3 clips maximum in our center. And we did indeed induce a partial stenosis. So we need always to measure also the gradient, that in this case you can see was a mean of 4, still under the 5 millimeter mercury, but for a tricuspid valve indeed quite a high gradient. And a very important moment also to guarantee the results of the procedure is to guarantee a good proper insertion of the leaflet. And this is the moment where we spend much more time to really check that the leaflet is well included in the clip, and how much of the leaflet, using all these different views, often going deep the transesophageal to see very well the grasping and the insertion of the leaflet. And finally, as I said, some specific point of attention only for the annuloplasty here. Obviously, the main target is the annulus, not anymore the leaflet, and particularly the inch between the annulus and the leaflet. We need, of course, to size the band, so that is done with the CT scan up front, but we confirm it during the procedure with the 3D echo. And then, as you can see here, we indeed guided the procedure with 3D and B-plane, where we constantly look at where exactly the tip of the leaflet is. And as you can see on the left upper panel, we see the tip really at the inch where the leaflet are, and we can follow on 3D the place of all the anchors along the annulus, and therefore the position of the band. But some of the anchors are very challenging, so we might have to use indeed the ICE echo, as you can see in this example, where indeed we often use to place some of the difficult anchors. So in conclusion, I'm very happy to actually repeat some of the important message of the NISA, because for us are really, really important. The selection of the candidate and upfront planning is really crucial, and for that we need an experienced imager that really master also 3D echocardiography and then knows all the specific requirements for each of these procedures.
Thank you very much indeed, Nina, for this very comprehensive presentation. I guess we have a lot of questions from the audience, but before I want to ask you, sometimes what we see is some kind of dynamic conditions. So we clip, we put one clip, and then we have some modification in the anatomy, so there are more indentation appearing. How do you deal with this during the procedure? Because this is unexpected usually.
Yeah, well, it's a good point. Indeed, we plan as much as possible, but we get always some surprises during the procedure itself. So when we place the first clip according to our plan, we always first check that we did it with the correct alignment, but sometimes due to the complex anatomy of the valve, the orientation of the distortion can be quite significant if you're not well aligned, so the insertion, as I said. But if that is correct and the valve assume a different conformation, you can see that what you planned maybe to cover in a specific jet happens in another way. So with the interventionist, it's very important to communicate and always adapt your plan to what you find during the procedure.
Excellent, Fabien. I guess
yeah, we have a lot of questions actually from the audience. So maybe I ask you some short question with a short answer. Maybe to you, Erwan. First, what is the problem you see with pacemaker lead? Is that any problem for imaging and for intervention?
It depends on the location of the lead. If the lead is in the commissure between the posterior leaflet and the septal leaflet, it's okay. It will not be an issue during the intervention. As opposed to the patient where the lead are crossing the tricuspid valve in the middle or in the anterior septal commissure, because in that case you have to push the lead during the intervention, and then it can be much more challenging.
And there is a lot of question about the definition of atrial tricuspid regurgitation. So I guess it's for you, Denisa. What is your definition? There is debate. Somebody said there is a lot of debate regarding that. What is your definition?
Indeed, we don't have a clear-cut definition. We have a definition in the American guidelines according to left ventricular ejection fraction more than 60, even if many other studies afterwards have used 50 as a cutoff for left ventricular ejection fraction. We have to have a normal right ventricle, a dilated right atrium, and tricuspid annulus, and no leaflet tethering. Recently, there is a paper proposing some quantitative criteria, like the mid-diameter of the right ventricle, which I think it's a smart idea because the basal diameter is not helpful, usually being too close to the annulus, and it's usually dilated in both. And also a distance of the tethering was suggested that more than 10 millimeters would be more in favor for the ventricular. I think it's useful to have also a sort of comparison between the dimensions of the ventricle and of the right atrium. And if you have a more than double ratio between the right atrium and right ventricle in size, in terms of area or volume, it's more suggestive for atrial with respect to a ventricular form, in which the dilation is more or less proportionate. But we need to to have more data and to test that. So at the moment, these are the main criteria, and one that I have skipped is the pulmonary hypertension that should be less than 50.
So it's an ongoing work, very interesting
Yeah.
definition actually, but it plays a very important role to define exactly the etiology of TR. Maybe we can go to your case, Ervan, with the presentation of the imaging live from the lab. Your patient had atrial fibrillation also, so we may have to deal also with a patient with atrial TR. So we go now to the description of the images of the case.
Welcome to the Rennes University Hospital. We will deal today with a patient with a tricuspid regurg. The idea is that we have to treat this tricuspid regurgitation with clips because the patient is still symptomatic despite the fact that we optimized the medical treatment and the diuretics especially. The patient is symptomatic, but we had checked before that the patient is active, that the patient has normal pulmonary pressure. It means that we did a right catheterization. We checked for the echoes several times, looking at the pressures, looking at the volemia, looking at the right ventricular function and the degree of the tricuspid regurg. At the beginning, the tricuspid regurg was torrential. And then, thanks to the medical treatment, you can see that now the tricuspid regurg is still massive, but not torrential. We will see during the intervention how the leaflets are, but hopefully we will be able to grasp these leaflets to treat the tricuspid regurg. So before that we start the intervention, I want to emphasize a few points. We have to optimize the medical treatment. We have to control the pulmonary pressures. We have to make sure that the patient is not too frail and will take advantage of the intervention. See you soon.
So thank you very much, Ervan. Very nice presentation, emphasizing also the role of preparation to optimize the patient for the intervention. What about the anatomy? What we saw on your images is that the jet is quite central with an anteroseptal component as well. Is that a good case for transcatheter edge-to-edge repair, or do you see also other options in that kind of anatomy?
Actually, the fact that we see nicely the leaflets, it's a good point to start with if we want to implant clips. And the fact that we have the maximal jet between the septal and the anterior leaflet is also good. The jet is quite localized, so it means that with 2 clips, probably we will be able to solve the issue of this patient.
We have also some questions regarding the assessment of the coaptation gap. So what is the best method to do it? And what are the criteria that you use?
That's a complicated issue, actually, and it's not standardized yet. But the point that I would like to make is that we have to measure the gaps where we are supposed to implant the clips. So it means that we will measure the gaps in the mid part of the septal leaflet and the anterior leaflet, and we will do the same in regard to the posterior leaflet. So we can measure the maximal gap in the center, but this maximal gap is more related to the severity of the TR than to the fact that we can clip or not. If we want to know if the patient is suitable for a clip, we have to measure the gaps where we are supposed to put the clips.
Is it a reliable measurement, the coaptation gap?
It's clearly not a reliable measurement because we demonstrated previously that the gaps that we are measuring in transesophageal views are clearly different from the ones that we are measuring using the transgastric view. So I prefer the transgastric view, but I can just say that it's my preference. It's not demonstrated that it's the good way to measure the gaps.
And is there any place for other imaging methods?
Not in the literature yet. We can perhaps use the CT sometimes, but it's not the usual way to do so.
Okay, thank you.
Okay, so I think we have heard that it may be a good case for edge-to-edge. Other strategies are also possible. Let's see what you did in your case. Let's look at the result as well, and then we will have some time for discussing at the end.
Hi, my name is Guillaume Laurent. I am an interventional cardiologist in the University Hospital of Rennes. So welcome in the cath lab, where with all the staff, we are going to treat the tricuspid regurgitation of these patients thanks to the TriClip device. So it's an edge-to-edge strategy. Erwan Donal presents you the case of these patients. So for this procedure, we start with a classical echo-guided venous femoral punction with pre-closing with a ProGlide. And now if we have a look at the echo images, we can see here in the transgastric view, we can clearly see that it's a tricuspid valve. It's important to make sure that the tricuspid valve is actually a tricuspid one, because as you know, sometimes we have 4 or sometimes 5 leaflets, but here we have 3 leaflets with a septal leaflet, an anterior leaflet, and a posterior leaflet. And as we can see here, the regurgitation is central and also in the anterior septal part of the valve. So we are going to put a first clip. We're going to use the largest one, that is to say the XTW TriClip, between the septal and the anterior leaflet.
So Guillaume explained to you that we will put a first clip between the septal and the anterior leaflet. So you see on this transgastric view with the biplane mode that we have the septal leaflet, we have the anterior leaflet, the posterior one, and then we have the regurg that is in the center of the valve and between the septal and the anterior leaflet. So the first clip will be put in the mid part of the septal leaflet. So we will use the transgastric view to guide the positioning of the clip, but it's not the only view we will use, because we also have to consider the transesophageal view, the deep transesophageal view, and the mid transesophageal view. And you see that, for instance, we will use this view to be able to clearly see the septal leaflet, and you see the chordae that are on the interventricular septum. And we will use this biplane mode, considering this, what we call the intercommissural view, and we will move this marker to be able to see all the leaflets and all the parts of the valve. It's very important to use both the transesophageal views and the transgastric view. So there was a puncture of the femoral vein, and then the device was introduced to the right atrium, and then we have the guiding catheter that is in the right atrium now, as you can see, and we will position the clip close to the tricuspid valve, making sure that the direction of the clip is okay to cross the valve, and to make sure that the orientation of the clip is perpendicular to the plan of the tricuspid annulus. So you see that we have in transesophageal view the tricuspid valve and the plan of the tricuspid annulus, and we will move the clip to make sure that we are in the middle of the valve, perpendicular to the plan of the tricuspid valve, and then we will be able to choose the location where we want to cross the valve, and then we will cross. You see that we are in the right atrium. The clip and the arms of the clips are open, and we will try to position the clip optimally. Before that, we select the location where we will cross the valve. So we are still in the transesophageal view, a bit deep transesophageal view, and we are trying to move the clip in the right atrium to find the perfect location to cross the valve. To cross the valve, they close the arms of the clip, and then you will see in this transgastric view and the biplane mode that they cross the valve in the middle, as you can see now. So you see the clip in the middle of the tricuspid valve, and then we will move very slowly, very carefully the clip to go in the mid part, in front of the mid part of the septal leaflet and the mid part of the anterior leaflet. So it will be done using the transgastric view, and then when we will want to grasp the leaflets, we will go back to the transesophageal view.
As Erwan explained you, we are just in the center of the valve, and we would like to go more in the aortic direction. So I have to push all the system if I want to go more aortic, and I can turn the guide clockwise if I want to go more septal, or counterclockwise if I want to go more in the anterior direction. And last, with the delivery catheter handle, we will turn it clockwise or counterclockwise in order to have the proper orientation of the clip, of course, to make sure that it's well perpendicular both to the septal and to the anterior leaflet.
As it has been mentioned by Guillaume, you see that now we are in the right ventricle. The arms of the clips are open, and you see that we are very close to the mid part of the septal leaflet, and we are probably catching the anterior leaflet with this arm. So it's quite nice because we are really where we want to be. We are not too much in the commissure, we are not too central, we are really in the mid part of the septal leaflet. So it seems that the anterior leaflet is taken. It seems also that the septal leaflet is taken. It's very hard to see and to make sure that we will grasp appropriately the both leaflet. Then we will move forward to the transesophageal view. Now we are in the transesophageal view, and you see on that view that we have the septal leaflet and the clip, and the anterior leaflet and the clip. So we have to optimize the views and to make sure that we can grasp appropriately both leaflets, if possible during the same grasping, and then we will see if it's not possible, we will do the grasping independently of the septal and the anterior leaflet. So we were not still very happy by the orientation of the guiding catheter. Then we still try to optimize the way we put the clip in front of the leaflets. And you see that now we have quite a correct way to grasp both the septal and the anterior leaflet. We are not too close to the commissure. We just check with the transgastric view. We are really in the mid part of the septal leaflet, so it's exactly where we want to be. And we will see if we can grasp both leaflets in that position. So you see that we have correctly the septal and the anterior leaflet, then we decide to grasp, and you see that we are just grasping, and we have perfectly the septal and the anterior leaflet between both arms. So it seems that we really catch properly both leaflets during the same grasping. So it's not completely closed yet. We can still change the location if we are not happy with this location, but at least we add both leaflets, and now we will check if it is effective to treat the regurg or not. So we see nicely both leaflets that are perfectly between the two arms of the clip, and then I can check with the color. So it's not completely closed yet. So maybe we can close the device completely to make sure that the regurg that we have in the clip will disappear.
Close, like that.
Ouais. So we can close. So that's nice. The closure was efficient, I think, but there is still a regurg that is quite perpendicular to the plan of the tricuspid valve. So we will have to check where is this regurg. So now we check using the transesophageal view and then the transgastric view. We see that there is still a regurg that is quite eccentric, but not a very important regurg. I will go to the transgastric view to see if this regurg is really between the septal and the posterior leaflet, or if it's between the septal and the anterior leaflet. I think it's between the septal and the posterior leaflet. So we see using this transgastric view that we have both the septal and also this part of the anterior leaflet, but there is still a regurg that is now between the posterior and the septal leaflet. This is the regurg that we see in that location, close to the center of the valve, and we see it also in the orthogonal view. So it means that we deal with the jet that was coming from the septal and the anterior leaflet, but now we will have to put a second clip trying to close the gap between the posterior and the septal leaflet. It will be a clover technique probably. It's not what we do most of the time, but for this patient it seems that we will have to do so. So we nicely see the clip, the septal leaflet, the anterior leaflet, and then the posterior leaflet, and the gap between the posterior and the septal leaflet. So we just insert the second clip that we will put between the posterior and the septal leaflet. So you see we are in the right atrium with the clip that is open, perpendicular to the tricuspid annulus and very close to the first one. So you see the first one, the first clip is there, and the second one is just behind. The arms are open, and then we will check using the transgastric view if we are in the good location to cross the valve or not. We are now in the right ventricle, and we are trying to position the second clip, as I told you. So we are quite nicely positioned between the septal and the posterior leaflet. So you see both arms that are open. So we are probably able to take both the septal and the posterior leaflet. We are not too close to the commissure. We are in the mid part of the posterior leaflet. So it's fine. So we will go to the transesophageal view for the grasping. So we add the clip that was positioned between the posterior and the septal and the posterior leaflet. We use the transgastric view, and you see that we see quite nicely both leaflets coming close together, and it seems that the grasping was okay between the posterior and the septal leaflet. So we have one clip between the septal and the anterior leaflet, and the second clip between the posterior and the septal leaflet. And then we will assess the result using the color Doppler. That's quite good. And then we saw that the result was quite okay according to the degree of regurg. You see that there is some small jets that we can see, but there is no huge tricuspid regurg as it has been at the beginning. So it seems that it's okay, and we will be able to deliver the second clip and assess properly the result today, of course, but also tomorrow in the echo lab before that the patient leaves the hospital. Because before that the patient will leave the hospital tomorrow, we will do a complete transthoracic echo to check for the quality of the result. So you see both clips are implanted, and we will let the second clip free of the delivery catheter. And it's not moving, it's perfect. We have both clips that are nicely looking at the same direction, which is nice. They are looking at the apex of the right ventricle. So the result is very nice. So the result is nice. There is a small jet of regurgitation, but not that much. So we will be ending the intervention now with 2 clips implanted. The remaining jet is mild, should I say, with a mean pressure gradient between the right atrium and the right ventricle of 1 millimeter of mercury. So it took something like 1.5 hours to implant these 2 clips. It was quite difficult because of the difficulties we had to get the perfect position for the second clip between the posterior and the septal leaflet, but at the end the result is fine, and we will see tomorrow in the echo lab how it's going. Just before we end the intervention, just to let you see the result using the transgastric view. So we have the septal leaflet, the anterior leaflet, the posterior leaflet, and we have one clip here and the second one here, and there is a real change in the anatomy of the tricuspid valve, and thanks to these two clips, the regurg is mild, and we hope that the patient will take advantage in his quality of life, and we hope that he will not have any episode of heart failure anymore, thanks to the medical treatment that we will keep, but also thanks to this treatment of the tricuspid regurg. Thank you, bye-bye.
So everyone, you seems to be quite happy with the results, but we have some questions. How do you evaluate the residual tricuspid regurgitation first? And second, when do you consider that you have a procedural success? And how far do you have to go for the number of clips that you will implant? When can you say, I'm happy with the results?
It's always a matter of discussion with the interventionist and the surgeon when the surgeon is in the room. So we discuss. We always have to discuss to make sure that we agree that we can implant another clip or not, because sometimes I would like to implant a third clip, for instance, but the interventionist don't think it's a good idea because the room available for that is too limited. And sometimes we have to deal with the chordae, with the anatomy of the tricuspid valve, so it's not always easy to make the success perfect, the success of the procedure perfect. So sometimes we have to stop the intervention with a remaining, with a tricuspid regurg that might be moderate, but we do so because we think that going further in the intervention could be harmful. So that's a matter of discussion. And then to assess the severity of the TR, actually, we shouldn't look at the color jet, but we do, I have to admit, that we look at the jet, where is the jet coming from, why is there a jet in that location, and then if we understand why there is a jet in that precise location, then we can understand if we have to implant another clip or not.
Can you still quantify the regurgitation as Denisa proposed in this setting?
Actually, I would like to during the intervention, but I can't. At least I do not. I did not this morning, and I will not do probably tomorrow. But when we are in the echo lab, it's completely different because we have the patient in the normal position. We can spend time to look at the quantitative tools, and then we do so. So we can use the 3D assessment of the LV and DRV to have the regurgitant fraction and the regurgitant volume. We can use the PISA because sometimes we have only one regurgitant jet, and then we can quantify this jet with the PISA, and sometimes the vena contracta also.
Excellent. So we have a lot of burning questions.
Yeah, so Bernard, we have a lot of enthusiastic comment also regarding your results. So congratulations, Erwan. And we have a lot of questions. So let's take maybe some minutes in addition, Bernard, if you agree, if you allow me to answer all these questions.
Because it's you.
And the first one is maybe for Denisa. You know, we have seen the transgastric view is very important in that kind of procedure, but also for the screening of the patient. So what are the trick and the tips and tricks you will give to somebody starting with a transgastric procedure and transgastric imaging of the tricuspid valve?
Well, first of all, I think we need to train more in obtaining this view because in regular patients, not often it is performed. Also because it needs the patient to be sedated because it implies a discomfort for the patient. So if we want to engage in a selection of patients and in guiding the procedures, we need to do it routinely, and not only on the left side, but particularly to train to see very well the tricuspid. And so for that, it is important to use the right flexion of the probe, so the small wheel, to have a good anteflexion, and also to know the tricks, but also the risks. And many times it's quite risky to move the probe when it is full anteflected, so the imager should limit the amount of time that performs unnecessary movements from transesophageal, deep esophageal, and transgastric. So when you train, you have to be aware of how to properly maneuver the probe in order to increase the safety of the procedure, but also to optimize the images. I think the only way to get better is to do it.
Yeah, train. That's
Nina, there was also a question from the audience regarding the impact of the Hahn classification in terms of anatomy. Do you have any clues regarding the risk of a successful procedure versus a non-successful procedure depending on this classification? In other words, the classical one, the type 1 versus the 2B versus another one.
Well, yeah, there are publications that show that unfortunately when the tricuspid is not tricuspid anymore, the results are less, and also with impact really not only on the immediate results, but also on the long prognosis, let's say. So it's something that we have to check up front, as we said, be prepared, make a plan, which are your targets, and hopefully by doing it more, we will learn also more, and probably results will be better also in that setting, but something that we have to be aware of.
Maybe Erwan, one other question we just talk about the challenges of obtaining a transgastric view. If you are unable to obtain because of anatomical reason or because the quality is not enough, do you think we can still go into a transcatheter edge-to-edge repair procedure, or that should be avoided? What is your practice?
It should be avoided. It should be avoided because it will be a nightmare. So we need to be able to see if we want to grasp the leaflets, and if there is one view that we cannot use, I think it could be very challenging. Expect if you are in a huge team with a huge experience and a huge expertise, but in a regular center, I think if you don't see, don't go.
And on the contrary, are you able to do a procedure only with a transgastric view, grasping? Because you mentioned in the case that you will, which is quite challenging, to change always the view. Can you do all the procedure in the transgastric view? Is that something you do, or?
Actually, I think we can, yes, because sometimes we do the grasping using the transgastric view. I know that some of us are doing the same thing, and it's very nice to see the grasping using the transgastric view. The only problem with the transgastric view is that we don't assess precisely the quantity of tissue that we have grasped. So we have to check for the anatomy of the leaflets after the grasping or during the grasping, but we are not completely sure that we have enough tissue, especially when we consider the septal leaflet. But still, I think the transgastric view is mandatory and could be good enough.
And one last question, maybe to both of you, Denisa and Nina, regarding pacemaker lead. So what would you advise to take attention to when you have a patient with pacemaker lead in terms of imaging and result?
So first of all, I think we need to have a high index of suspicion that the TR can be significant. If it doesn't, because of the shadowing artifact, you might underestimate it. So we need to use both transthoracic and transesophageal. If the patient has right ventricular failure symptoms, we need to have a high index of suspicion that the TR may be more severe than it appears. And as we said already, the 3D is essential, or a very good short axis view of the valve. Let me say, if you have a transgastric view, you can also see that if the pacemaker is in a commissure, usually in posteroseptal, but if it's not, then it may be impinging or fused with a leaflet. So 2D, unfortunately, longitudinal views of the valve are not reliable for this diagnosis, and this makes a huge difference in the management and also into the indication for an intervention.
Nina?
Yeah, I agree. Advanced imaging is really important to understand the mechanism. And once you have understood, you can make a plan. It's not a no-go for certain procedure. If it's in a position, you could clip it inside, let's say, the commissure, for example. Or in center with expertise, we have done also extraction with placement of leadless pacemaker and then the procedure afterwards. So you can make a solution, but only if you understand the mechanism. And that is where imaging is very
For those who are interested, there is an excellent paper recently published in the Journal of the American Society of Echo last week. So regarding the algorithm that you can use if you have a suspicion that you have a primary TR, severe
CAD.
TR related to the to CRD. Yeah.
Thank you very much, Bernard. We are a little bit above our time, but that's because you were extremely active and asked a lot of questions. So thank you very much for your participation. I think we have very nicely seen the challenging of imaging the tricuspid valve first, then the importance, and we have talked a lot about this, of the recognizing the appropriate etiology of tricuspid regurgitation, and finally we have seen very nicely the value of the cooperation between imaging and interventional cardiologists, and it was very nice to see the perspective of the guiding echocardiographer during an edge-to-edge procedure. So thank you very much. The last words are yours.
Thank you. Just to thank the very active attendance and also to thank you for the nice invitation and to say very good evening, and see you soon for maybe more information. Bye-bye.
Bye-bye.
Bye.